Jessica Gorham, and I'm the Regional Emergency GBV Advisor covering East and Southern Africa, based at working on behalf of the GBV AOR, which is the Global Coordination Mechanism for Gender-Based Violence in Emergencies. But for today, I am also in my capacity as the co-chair of the Regional GBV Working Group for East and Southern Africa, which is co-chaired by the GBV AOR and CARE International. So thank you for joining our monthly webinar series, which we call our Emerging Practice Series. Every month, the Regional GBV Working Group hosts an emerging practice or some other sort of topic that we think is relevant to do the work that we do for GBV prevention and response. We're really excited today to welcome two of our presenters. First, we will have Joanne Crichton, who is the Program Director for the GBV AOR Help Desk. And the Help Desk has recently completed a wide breadth of work, which is a research paper on one-stop centers, looking at standard operating procedures, best practice. And then I'm especially glad to welcome Sharon Matingwina, who is the Programs Manager for Musasa in Zimbabwe. And Sharon and her organization have been implementing different types of one-stop centers in Zimbabwe since around 2014. So we'll get a closer look at some of those ideas that Joanne has put on paper in practice in Zimbabwe. So we're excited about today's session on one-stop centers, particularly promoting standards in how we do business in one-stop centers, because I think a lot of us are working in countries that use one-stop centers as a main source of response services for survivors of GBV. And we here at the GBV AOR and also at the Regional Working Group want to make sure that the services we provide are to a standard or a global standard of care, and that we don't inadvertently cause more harm by the work that we're doing. So without further ado, Joanne will start us off. And then after Joanne speaks for approximately 20 minutes, we'll have about 10 minutes for a question and answer. And then we'll head over to Sharon's presentation, and again, another 10 minutes for questions. As usual, everyone will be on mute throughout. If you have a question, please write your question in the chat. I will be curating or moderating the chat. So I will write down your questions and then present them to the speakers. And this enables us to actually get more questions in, and then so that we can also group like questions together. So again, if you have any questions, please do put them in the chat, and I will be able to write them and present them to the speaker. So without further ado, I'd like to hand it over to my colleague, Joanne. And again, thanks for joining us, Joanne, and over to you.
Thank you so much, Jessica, for that warm welcome. And hello, everybody. It's a pleasure to be with you all today and to have this opportunity to join you. As Jessica shared, my name is Joanne Crichton, and I'm the Program Director for the Help Desk, the GBV AOR Help Desk. I'm also a Senior Technical Expert for GBV and Emergencies with Social Development Direct. For those of you that may not be so familiar, the GBV AOR Help Desk is a free and confidential technical advisory and research service for all humanitarian actors working on GBV risk mitigation, prevention and response at the local, country, regional and global levels. The services we provide complement and are certainly not intended to replace the support that you receive directly from your own organization or technical advisors and your RIGA. We're here as an additional form of support for you. I will be presenting today on behalf of Emma Bell, who is a technical expert for the GBV AOR Help Desk, and sharing key information about a paper she wrote, which was based on the available written evidence in relation to one-stop centres. And so let me please explain that this piece of work originated as a query which was submitted to the help desk by a professional working on GBV in emergencies who wanted to find out more about this service delivery model and how one-stop centres operate and any SOPs associated with them. So the title of the paper that has been produced, and I will be sharing a link in the chat later after my presentation to the paper itself. The title of the paper was One-Stop Centres, Models, Standard Operating Procedures and Guidance. And our research methodology included an online desk-based research related to guidance on one-stop centres, looking at searches and databases and websites of relevant organisations, and by further outreach to key organisations and initiatives, such as the GBV AOR, Community of Practice, and Spotlight. So there are some limitations which I think it's important that I point out to you at this point, which is that the resources in the paper that the paper draws from are limited to English source documents. And they're also, as I say, mostly based on publicly available online materials. So we fully recognize that there could be what we call grey literature or materials produced by INGOs, NGOs, local organizations, and other GBV or health actors that are not easily available online or that we were able to include. I should also add that this query was produced within a rapid time frame and turnaround time in order to support the person who made the query make some informed, rapid decisions for their emergency programming. And so certainly I would not like to claim that this paper is exhaustive or fully comprehensive, but rather please consider it to be a snapshot of the available evidence, mostly drawing on literature from 2010 onwards. And also, I would just like to add that we have a special caveat in relation to women and girls safe spaces, which I will mention later, but some women and girls safe spaces wish to be included and would consider themselves to be one-stop centres, and others wish to be considered as a service model in their own right. So that is something that I feel I should indicate from the beginning of this presentation. A little bit about one-stop centres, and if you like, perhaps a definition. One-stop centres provide integrated, multidisciplinary GBV services in a single location, or they can be organised as a system of either formal or informal networks. So some brief history and background on one-stop centres was where we began. And for your information, for those that this may be new information, sexual assault response teams and sexual assault referral teams were first developed in the US and UK in the 1970s with the objective of facilitating reporting and medical examinations for survivors, to coordinate investigation and support services, and prevent survivor re-traumatization when seeking care. The original one-stop centre elsewhere in the world was developed in a tertiary hospital in Thailand, and this aimed to provide acute services to survivors of violence. One-stop centres were established in Malaysia in 1994, and the model was replicated throughout Southeast Asia and Western Pacific regions. It has now been widely implemented with donor support in several African and Middle Eastern countries, with similar models emerging in Latin America. The majority of one-stop centres are hospital-based, typically within tertiary care facilities, while others are standalone centres that provide basic health services on-site and referrals for specialised and emergency services. Some one-stop centres are more strongly linked to the judicial system, as in the case of some of the one-stop centres in Mongolia, Zambia, Delhi, Namibia, and the women's justice centres in Latin America that were considered as part of this research. So now let's consider the main one-stop centre models as mentioned, they are mainly services located in hospitals. However, there are also examples of one-stop centres that are located elsewhere, for example, within communities or other health facilities or police stations, for example. In some countries, organisations offer a variety of models, and this query, this desk-based research query, provides information about examples where different models have been implemented and compared. For example, one-stop coordinated response centres for GBV operated by Care International in Zambia, 8 one-stop coordinated response centres led by Care were set up in 7 districts to help survivors of GBV access a comprehensive package of integrated medical, legal and psychosocial support. CRCs were embedded into a network of government, health and police, and non-governmental counselling, legal and shelter services. CRCs provide direct services which focus primarily on medical services, psychosocial and paralegal counselling, and also refer clients to social services, support groups and shelters. Village-based one-stop centres, hospital-based one-stop centres, fast-track GBV courts and savings groups, of which is a multi-pronged GBV strategy in Zambia. These village-led one-stop centres were in 21 districts with a further 6 planned, serve as a community platform for outreach efforts and first-line response before referral to other service providers. And you can see on the screen further information about the different one-stop centre models. In addition, in relation to women and girls safe spaces, these have strong referral pathways and invite sector-specific specialists in or have other services based within them, such as health screening and a legal advisor on a range of rights issues. There are also, as you can see, one-stop centres located in other sector services. This often refers to police stations, but can be with courts, counselling services, refugee camps and shelters. There is, as you can see, some overlap with the standalone model. Now on the screen, you can see, hopefully see an illustrative table, which simply gives an at a glance indication of each model's comparative advantage with providing different types of services. I would like to point out, however, with full funding and at the right level of funding and commitment, each model could provide the main services needed by the survivors, which are indicated along the top of the table. And again, a caveat that this information is based on the available written documentation that was reviewed, mostly consisting from 2010 onwards. And to note, some providers of women and girls safe spaces considered their services to be a form of one-stop centres, and others did not identify as such and consider this to be a specific model in its own right. So the models that you can see can also be characterised as follows: providing provider-level integration, facility-level integration, and systems-level integration. Now, what do we mean by each of those? Well, provider-level integration is where the same provider offers a range of services during the same consultation. For example, an emergency room nurse is trained to screen for IPV, counsel the patients, and refer them to external services. It is the least expensive model to implement and does not rely on multiple stakeholder buy-in. However, because the model relies on training individuals, when a practitioner decides to retire or change profession, the investments in human resources can be lost. This emphasis on individuals also can affect one-stop centre outcomes. Well-trained, committed practitioners may be able to make a huge impact in their communities, but those who perhaps do not have the benefit of being well-trained or committed or either will perhaps not. What do we mean by facility-level integration? This is where a range of services is available at one facility, but is not necessarily provided from the same provider. Some see this example as a classic one-stop center. A nurse in accident and emergency, for example, may be able to treat a woman's injury, but may not be able to provide counseling and case management to a woman who discloses domestic violence. And so she therefore may need to refer the woman to a GBV caseworker or a hospital-based social worker for that service. Systems level integration. What do we mean by this? This is where there is a facility level integration as well as a coherent referral system between facilities to ensure the client is able to access a broad range of services in their community. These are rare in lower income countries because of the costs involved in ensuring that services that are part of the referral network are fully on board with the initiative and fully integrated into government structures and given sustainable funding. However, certain initiatives implemented in Zambia, DRC, Nepal, Sierra Leone, Kenya, Rwanda, and Sri Lanka that were considered as part of this desk review aim for system-level integration and rely on a set of external networks to provide services that cannot be provided in one place. For example, in Nepal, active, well-networked, one-stop crisis management center focal points are key factors in making coordination with external agencies work well and for smooth referrals to happen. Now let's consider some of the advantages and disadvantages that were found from examination of the available research papers. For hospital-based tertiary care one-stop centers, these tended to be better equipped to provide medical services, but perhaps not so equipped to support women's psychosocial care and to achieve legal outcomes. They mainly focus on the physical and sexual forms of gender-based violence that can cause physical harm and may be less adept at dealing with a broader range of or types of GBV, or indeed applying a feminist gender transformative approach. It was also found through the literature that there can be power differentials between doctors and counsellors, which can lead to the doctor's request for resourcing and supplies getting priority. And so there can also be some exceptions to the, as you can see, there was a mention that they are less likely to achieve legal outcomes, but as always, there is an exception that challenges the rule. And in Zambia, for example, we found that there was an increase in legal outcomes with the linking of village-led and hospital one-stop centres to fast-track courts. When we look at health facility-based one-stop centres, which are run by NGOs or INGOs, the Family Support Centre Health Services for Urban Survivors of Gender-Based Violence in Lao, Papua New Guinea, the FSC at the National Department of Health's Provincial Hospital had a core group of staff who were committed to addressing GBV. MSF's operational centre in Amsterdam provided the medical, management and human resource and material support to the FSC for the provision of medical care and counselling services there from late June 2007 until 2013. And the overall finding was that health facility-based OSCs run by NGOs tended to provide better psychosocial support and have a better understanding and approach to gendered power dynamics. Having one-stop centres within other facilities, such as a primary or maternal healthcare clinic, has the potential for broader reach, but tend to be dependent upon referring women externally to a range of specialised services. Now let's take a look at standalone one-stop centres. These may offer a safe, non-discriminatory environment, but are not always possible in hospital settings where staff are not necessarily all GBV specialists. One-stop centres in women justice centres are successful in creating access to legal pathways for survivors to pursue justice. There were some challenges, however, at times in meeting medical needs, particularly acute or emergency specialty needs. And there can be challenges in identifying suitable and accessible locations, staffing them and ensuring 24-hour coverage, including for security. For one-stop centres located in other sector services, these can be strong in terms of safety, legal aspects, policing, and sometimes psychosocial services. However, the provision of healthcare and mental health care can be a challenge. Also to note, they can at times and in some settings and contexts not be appropriate or easy for women and girls to seek help from, given the focus on the legal and justice aspect. This is particularly the case where there are highly discriminatory laws against women and girls, or attitudes and beliefs need further transformation. So overall, the key findings around advantages and disadvantages can be summarized as the advantages of the one-stop center models are that they can provide efficient and coordinated services. They aim to offer a full range of services, although to note at times that this is not always feasible. They sometimes include police, prosecutors, social workers, counselors, psychological support for survivors. This can reduce the number of times a survivor must repeat their experience and the amount of time that they spend in seeking services from different providers. Disadvantages of the one-stop centers models are that overall that they tend to require more space and resources. The client load may be small in rural areas, for example, though not necessarily. This can raise cost concerns, and they may draw staff and resources from other specialized services to staff these centers specifically. They may also not be fully integrated into general health services. And I know that I'm almost at time, so I will not cover this in too much detail, but I'm happy to speak to this further, perhaps in questions and answers. But in general, there were some additional findings, as you can see on the screen. Overall, there is a need to further strengthen coordination across sectors, even with one-stop center models, even with integrated one-stop center models. Additionally, it's really important to consider further embedding one-stop centers into a wider system to ensure that there is long-term commitment to the sustainability of these services. As Jessica mentioned at the start, we also examined some standard operating procedures that have been published in relation to one-stop centers and other forms of relevant guiding documents. SOP examples that we found and that are referenced within the paper include those from Somalia, Mali, and Bhutan. And in relation to women and girls safe spaces, there are core documents such as the IMC and IRC Women and Girls Safe Space Toolkit and the UNFPA IRC SSWG Bangladesh Standardization and Technical Guidance Note. And so thank you very much for listening to me provide this overview of the One-Stop Center paper that Emma Bell wrote in response to a query that came through to us at the help desk. And if you should need any desk-based research to inform your work or have a rapid technical support query, please don't hesitate to get in contact with us. And our contact details are on the screen, and we'll also be sharing the presentation. So thank you so much for your active listening. I'm available now for some questions. Thank you, Jessica. Over to you.
Thank you, Joanne. We did have a very active chat during your presentation, so lots of really good questions. We have approximately 10 minutes for the questions, so I will try to get all of them. As I said, I like to group them together. So lots of questions about the health aspects. Our first question was from Eric from UNICEF, and was there any experience or feedback around the coordination of the interagency services? So based on identified needs and gaps. Throughout your research, did you come to any conclusions about coordination of interagency support? Joanne.
Thank you so much, Eric and Jessica, for that question. In relation to coordination, overall, as I mentioned in brief, it was noted that there is a general need to strengthen coordination across sectors, because without strong coordination, this limits one-stop centers' ability to provide quality, accessible, and timely support to GBV survivors. And for health specifically, that would include making sure that there is, for example, a smooth supply of needed clinical management of rape kits, for example. Also ensuring that there's best use of resources through coordinated trainings for taking care of the health and psychosocial needs of survivors. It was noted that an enabling factor for providing quality one-stop center support services is really to be able to have regular interagency meetings to coordinate services and support. This also allowed a space to be able to address challenges and to delegate tasks. It can also, it's also very helpful to have that smooth coordination, as it can also support effective diagnostics, medication supplies, as mentioned, and this in turn, when things are running smoothly, then minimizes return visits that are needed by survivors when everything is available. So I think those, in summary, just at the top line, key takeaway points that came out in relation to health coordination or interagency coordination regarding health.
Great, thank you. We had a couple questions around legal and police services, so I will group these together. One of our participants had asked if you had any or came across any models that incorporated both the customary and the statutory legal systems and how they address those in the one-stop model. And then also the issue of mandatory reporting. I think that one came from Kenacheno from Mozambique. So one is about customary versus statutory, are both provided at OSCs, and then the issue of mandatory reporting, if any of those came up in your research.
Thanks so much for those questions. They are great questions. I may need to defer to the author of the paper, Emma, on those issues, but to my understanding, within the literature, mandatory reporting did not specifically feature from the literature that was reviewed, although I'm sure, as you're all very aware, that mandatory reporting regulations can affect the way in which services are provided to GBV survivors. In relation to the other point, sorry, Jessica, could I ask you to repeat that?
Mm-hmm. It was customary versus statutory services, and then the mandatory reporting.
Thank you. Regarding customary versus statutory, I think what we found was most of the services where there were legal or police actors within the one-stop center model tended to be from the statutory aspect. However, I hypothesize, as I say, I am not the author of the paper, but where there is a survivor who is accessing a caseworker, we know that if a caseworker is providing survivor-centered case management, they would seek the needs and wishes of the survivor and may make referrals in accordance with those needs and wishes of the survivor. So that would be, I think, what I can say to that at this point on that point, but it's a really interesting question, so thank you.
And I'm also putting in the chat, because we did have a few questions about quality of services. And I want to remind everyone that we do have the GBV interagency minimum standards, which speak to every one of the services that potentially could be provided at a one-stop center. And so if you're looking for a basis or a foundation of what we consider a minimum, remember, this is a minimum. This is what also we want to promote even higher. But please go, I put the link there, and the link is to the GBV interagency minimum standards for programming. And it addresses both all the legal aspects, it addresses the health aspects, the psychosocial support aspects, all of the minimum sort of criteria for each of those services. And you can adapt those certainly for a one-stop center as well, because we did have we had a couple of questions around standards. So just note that was in the chat, and those are the GBV interagency minimum standards for programming, and it addresses each of the services that would be provided. There are 16 of them. And I know we're running on time, so we'll do 2 more questions. This is a good one, I think, as well, Joanne, in terms of setting expectations. And being transparent about what we can and cannot provide. We had a colleague from Ethiopia who said a lot of our OSCs are based at hospital levels, but is it possible then to also roll those out at health center level or more of a community level? Over to you, Joanne.
Thank you, Jessica. Thank you for that question. Yes, it is possible to do so. Maybe I will just take us back to one of the slides to kind of help to indicate this. So you can have, as you've mentioned, the hospital-based care at the tertiary level. You can also have health facility based, so meaning at any specific health facility level that is provided and which are usually operated with support from NGOs or INGOs. There are some, it is important to make sure that there are, of course, that within any of these facilities that there is it's a safe space, that there is confidentiality, that there are trained staff, so that, in other words, we're meeting the standards that Jessica was speaking about. You can also have, as I say, standalone one-stop centers, which perhaps focus more on the psychosocial or perhaps legal aspects. And it may be that then survivors are referred elsewhere for health services, although not necessarily. You may, for example, have a visiting doctor or midwife or other health staff that comes to provide support. You could also have services provided in other sectors. As I mentioned, there are some examples of where these have been integrated into a police department or a local police office. Although, as noted, that this may be a challenge for some survivors to seek help from those types of service point. So I hope that answered the question.
Yes, thank you. And then for our last set of questions, I think this also, and I saw Martine from the Swiss Development Corps, one of our donor agencies, also had a question around the capacity of staff at the OSC. So first, if we could, if during your findings, if there was best practice on how you maintain capacity. So that would be the first, because we had 2 follow-up questions, and I think one was if an OSC, if we can have an OSC, if we don't have, for instance, professional counselors on staff for reintegration. So is it ethical to have an OSC when we don't have the level of staff that we need available? And then I think Harriet Adong, one of our colleagues from Fiji, had said, so in the absence of, say, a doctor, could you then start training midwives to take over some of these functions? And so this really speaks, I think, to capacity, and this will be your last question, Joanne. First is, what was maybe the consensus in the research about staff capacity? And then second, can you still ethically have one-stop centers when you don't have what many would consider the sort of global standard? And are we able to provide services when we don't have, say, trained or professional counselors? Are we able to train midwives in place of doctors? Those are the kind of questions that I grouped together. Over to you, Joanne.
Thank you so much. So I think one important thing to note is that this particular desk research really didn't focus perhaps on the staffing, the training, the capacity piece. It was really examining the models, the overarching models, and what's known. So in the course of that looking at what was found, I can pull out some pieces, but it probably wouldn't be such a comprehensive response to the question around training and capacity, which might highlight the need for further examination or further research on this area. So I think what was clear is that depending on the model that you use, there will be some in strengths to that model, and potentially some drawbacks to that model. So, for example, as I mentioned, when it comes to hospital-based tertiary care, as we noted, it may be that you have trained medical staff, but it may be that there are then power differentials, as I mentioned, which could impact the service level or the support for the other professionals, other sectoral professionals within that facility that are providing support to survivors as well, because health is seen as perhaps the dominant profession by nature of it being located within a hospital or a health facility. So I think that was the main takeaway. The other point from the literature was in regard to making sure that there is that there are the range of services or access to the range of services that a survivor might need is very, very important. And I think aside from the literature, speaking with a program's perspective and beyond the scope of the paper, I think this brings us back to Jessica's point about referencing and understanding the standards, really having thorough assessment of the needs of survivors in your location and being clear on making sure that there is sustained effort to have a cross-sectoral response that's going to meet the needs, the diverse needs of diverse range of survivors. So I'm sorry there's not a silver bullet answer on that, but clearly investment in building training and capacity building staff and professionals across the range of sectors that were mentioned. So for example, in case management, clinical management of rape, legal, psychosocial support, and on being able to make safe referrals will be incredibly important in delivering quality services for survivors. Thank you.
Thank you, Joanne. That was super helpful. And you had mentioned that you will put the link to the,
yes.
Okay, that would be great because we have people asking about it. And I just want to also reinforce from a coordination perspective, and many of you had asked, are there ways that we can bring one-stop centers down to the community level? And always at the foundation of all of this, all of these questions is, can we provide a service or services that do not cause more harm as well? So it's not enough for us to roll out blanket, we say we're going to roll out 10 one-stop centers in a month, which we know would not meet a standard of care. And we also know that if a survivor, and we've had studies that have looked at this, if a survivor does not receive the care that they are due with the respect and confidentiality and even the technical expertise, they won't return most likely for a service. And so we have to keep all of that in mind, that it really is important for us to make sure that the services we deliver don't inadvertently cause more harm, both just physically during a treatment, but also because we know a survivor won't return if they don't think that they're getting a respectful or confidential or even technically sound service. So then we could in fact be inhibiting future survivors from, accessing services. So something to really keep in mind about when we're rolling out one-stop centers. We often think of it as our indicator is that we roll out a center and we're done. But so important to make sure that our staff are appropriately trained to deliver those services, or else we're inadvertently causing more harm. And that is something we don't want to do. And it can even cause more trauma. And so we want to make sure that we're adhering to those standards. If you have questions about how to set up one-stop centers or the capacity of the staff of a one-stop center that you are currently providing, please do reach out to the GBV AOR or to the coordination mechanism in your country, your GBV coordinator. Most of the countries I see online do have a working group, either nationally or a subcluster, and that's exactly where you can go to receive more information or also to set up more comprehensive capacity building. Yeah. So thank you again, Joanne. I think we'll move over. So we have a lot of good, I think, seeds here about how we can implement one-stop centers. And Sharon is about to share her screen. So we have Sharon I just had it. Matingwina from Musasa. She's the programs manager, and they have been operating one-stop centers since 2014 in Zimbabwe, in both humanitarian and in development contexts. And more interestingly, Sharon, we had a lot of questions about how we do this more at local community level. And so maybe if you could speak a little bit throughout your presentation about capacity, but I'm really excited because they also have a model which is a mobile one-stop clinic. And so we'll hear a bit more about that. So Sharon, you have 10 minutes and then we'll have another 10 minutes for questions. So over to you, Sharon.
Thank you so much, Jessica. You really tried on the surname there. Well done. So my name is Sharon Matingwina from SASA Project, we're a women's rights organization in Zimbabwe. I'll go through my presentation.
And Sharon,
we're able to
sorry, oh, you did it. There we go. Thanks.
Okay, are you able to see?
Yes, we see you well.
Great. Okay, so I'll start with the static one-stop center, and thanks to Johan, who has really explained in detail the different types of one-stop centers. Through my presentations, you also see the two types that we are currently running in Zimbabwe. So we have the static one-stop center, which Musasa was able to set up in Harare, is the first ever in 2014. And I think through that, over the years, we've been able to draw a lot of lessons from setting up of the one-stop center. So the one-stop center offers a comprehensive package of care to survivors. And the staff complement comprises of legal officers, nurse counselors, counseling psychologists, and social workers. So this answers Jessica's question around the capacity of the staff that mans and supports survivors within the one-stop center. It's a combination of service providers that are able to offer legal services, but also able to offer psychosocial support. So it's a combination of nurse counselors, those that can give clinical care, psychosocial support, and legal services. The OSC model, OSC is an abbreviation. I saw someone writing a question. It's an abbreviation for one-stop center. reduces recurrent trauma for survivors, so that when they move from one place to the other, they do not get the same questions over and over again, which results in recurrent trauma. So it's important to have at least one area where they can get a comprehensive package of care, and they're able to access medical support, legal support. It also reduces the traveling costs and all the accompanying costs that they may go through. So Msasa, sorry, there's some feedback. Msasa thus sought to bring as many services as possible for survivors of GBV under one roof, and this to date remains a well-appreciated model by women and girls from all walks of life. Okay, I'll move on to the Mobile One-Stop Center. The Mobile One-Stop Center was established against the background that the unavailability of effective GBV referral systems often makes it difficult for women and girls to access services, because most services are centered around the provincial and district level, which then negatively impacts on timely life-saving service uptake. So with support from UNFPA, the Mobile One-Stop Center model is a flagship model within the Zimbabwe multi-hazard context, where we are looking at emergency situations ranging from drought, floods, cholera outbreaks, Cyclone Idai, COVID-19, among all the other multi-hazard contexts that the country has been going through. This has increased access to multi-sectorial GBV services in remote and hard-to-reach areas. So the idea of Mobile One-Stop Centers is to bring services closer to the community. Our team often calls it hashtag services within reach, or hashtag bringing services closer to the community, upon the realization that there are multiple challenges that women and girls face in accessing GBV services, especially in the remote areas, in multi-hazard context-prone areas, or GBV hotspot centers. So Msasa has been able to set up over 20 mobile one-stop centers in 20 districts since 2019, and we've had lots of learnings from setting up mobile one-stop centers. Similar to the static one-stop center, the Mobile One-Stop Center also provides the same set of multi-sectoral services, but this time it will be on wheels, and communities are able to access in the comfort of their ward or specific village. The Mobile One-Stop Center team comprises of the police, which is the victim-friendly unit officer in our context, an SGBV nurse who is able to offer SGBV clinical care and counseling to survivors, a legal officer, and a counselor. You realize that in most remote or vulnerable communities, it's difficult for survivors to access all these services under one roof. So the mobile has become one of the most preferred mode of one-stop centers by communities. The Mobile One-Stop Center operates on a rotational basis, with the teams roving across all wards of any district for 1 or 2 weeks every month, depending with the context or the area where we are implementing or the specific program. You'll see a photo right next to my presentation showing one of our counselors offering mobile one-stop centers in Cyclone Idai season. I'll then go through to our best practices. One of the best practices is that identifying context-specific entry points is one of the key things that is important. In setting up static one-stop centers within health facilities, e.g. provincial or district hospitals, facility service uptake while ensuring confidentiality through health-based entry points. So it's important to identify context-specific entry points. It's also important, and as one of the best practices, to have flexible setup. Mobile one-stop centers integration within mobile health clinics and outreach ensures access to comprehensive package of health services. So when you're offering mobile one-stop centers, you should include a whole lot of packages for survivors to draw from. You can have your health service providers offering COVID-19 vaccination campaigns, while at the same time also raising awareness on sexual reproductive health rights, but giving critical GBV services at the same time. It's also important to work closely with government. This makes the OSC models more sustainable. For example, the secondment for our SGBV nurses comes from health facilities within our government. We get the police, of course, from the victim-friendly unit under the Zimbabwe Republic Police, so that even beyond this project cycle, the stakeholders can continue offering services. So it's important for sustainability, but for also strengthening the community referral system. One of the best practices also in offering both static and mobile one-stop centers is the disability inclusion. When we're implementing our one-stop centers, we take the leave no one behind approach. So disability is at the heart of the work that we do. Our static and mobile one-stop centers are equipped to offer services to persons with disability, with our staff trained on basic sign language and exposed to a lot of disability inclusion materials. Our staff actively participate in disability training so that their skill and knowledge is also enhanced. One of the key things also in offering mobile one-stop centers and static one-stop centers is strengthening the community-based GBV surveillance and referrals. So in our context, we are working with a combination of village health workers, behavior change facilitators who are based within the community, and they raise awareness both on gender-based violence, sexual reproductive health, but also importantly refer survivors to the one-stop centers. They play an important role in identifying all the survivors and most survivors that are referred to the mobile one-stop centers. But ultimately, they also play a critical role in strengthening the community referral system so that beyond even the program cycle, the GBV community referral system can remain strong. In some districts, we have piloted the e-referrals through smartphones that were given to community cadres, and these have really enhanced referrals and case management for survivors that are stuck in the most remote parts of the country. We also have a shuttle system as one of the best practices we've picked from our one-stop centers. It enhances movement for survivors, especially in emergency situations, so that they are able to move to the static one-stop center or to the mobile one-stop centers, or sometimes to the shelters that we critically link to the one-stop centers. We also prioritize care for the carer. We realize that all the frontline staff offering services to survivors go through a lot of burnout. So we ensure that they receive heart, mind, body debriefing sessions to help them with burnout, but it also then improves their quality of care because you cannot pour from an empty cup. So our debriefing sessions were done both physically and also online, especially during COVID-19, to ensure that our staff remains motivated, but also get a chance to reflect and debrief on the experiences that they go through. Thanks. Over to you, Jessica. I don't know if you have any questions in the chat as yet.
Thanks, Sharon. Those are great. Yes, I've been furiously marking down questions. So I am going to close the questions in the chat at this time because we have 10 minutes left for Sharon to answer those. We have a lot. So I'm again going to try and consolidate. We had a couple of questions around confidentiality. And so if you could expand upon how do you maintain confidentiality, both for the static, but people were very interested in your mobile model because I don't think we see that as much. So how are you ensuring, since it looks like that picture right there, for instance, is women on a bench out in a seemingly very open space, and they'll go to a van that's also quite open. How are you ensuring confidentiality in these kind of humanitarian contexts? What is the first one? Over to you, Sharon.
Okay, thank you so much, Jessica, for that. So for our static one-stop center, it's the easiest because we are set up where we have very private offices, which makes it very unique and easy for survivors to access. But for the mobile one-stop centers, we use mobile tents that we pitch up every time before we start mobile counseling. This ensures that in between the session, when you're having a session with a survivor, confidentiality is guaranteed. It is a promise that we give to our survivors, but also also a commitment that we draw from the standard operating procedures. So the mobile tents are quite handy because it's like a private room, as you can see from one of the photos. So women can queue up for various reasons. They can say, I'm coming for family planning. They can say, I'm coming just to seek information around GBV. But within the tents, that's when they can pour out their issues. And that way we able to ensure confidentiality and the privacy of our survivors. That is both for our static and our mobile one-stop centers. I don't know if that answers your question.
It does. So Sharon, just to be clear, is this part of a larger reproductive health service provision as well? So it's not specific to survivors of GBV?
It's specific to survivors of GBV, but they can get over and above the psychosocial support services that we give. They can also get family planning services or any other SRA, HRA services. As I have said, flexible setup is one of the most important things in setting up mobile one-stop centers. So you can offer GBV services, but also ensure that access to clinical care, a combination of COVID-19 vaccine or sexual reproductive health, also complements critically the GBV services that we are offering, because we are looking at women and girls who are set up in very remote areas whose access to clinics or to hospitals is actually a nightmare. So bringing a comprehensive package of care is very important.
Okay, good. So interesting. I think people are really interested around those key principles of care, which are respect, confidentiality, non-discrimination, and safety and security. So probably if we had more time, we'd love to get more information on how you ensure safety. And then also, as we said, confidentiality to ensure that survivors don't feel stigmatized as well. And we did have a question around stigma, and I think that might be another conversation because we do only have a few minutes left, but I think important for us to think about at this one-stop model. But I'm intrigued by it because you do tick a lot of these boxes that we present as challenges. Another grouping of questions is about follow-up. How do you ensure, since it's a mobile service, how are you ensuring that you have a follow-up service, particularly for health and other services, and actually psychosocial as well? How do you do follow-up services when you have mobile services that are not daily? Over to you, Sharon.
Thank you, Jessica. So part of our case management is really serious on client follow-up. So that we ensure that we give a thorough case management. So we do phone calls for those that we are able to phone right after any intervention. We also do home visits because we are targeting very remote areas where sometimes network is erratic and getting hold of survivors via phones can be a challenge. So we also do a combination of phone calls, home visits, but critically also use the behavior change facilitators that we trained in this program on gender-based violence and on the referral system to help us to identify cases where we may need to find out if the safety of the survivor has been enhanced. We also complement our one-stop centers, both static and mobile, with a toll-free. We have a national toll-free that is reached by survivors across the country, as well as shelters. So for those that need long-term protection, we refer them to both our urban and our community-based shelters. So each service is complementing another in order for us to ensure that thorough case management is done. Thanks. Over to you, Jessica.
Thank you. And I noticed that we had a follow-up in the chat from Verena Bruno, who is also the subcluster coordinator, the GBV subcluster coordinator in Zimbabwe. And I see, Verena, that you gave a bit more texture to the issue of confidentiality. So do look in the chat that Verena did speak a bit more about confidentiality, and it does look like they are integrated into broader services such as mobile health clinics and mobilization for other services too. So thank you, Verena. That's well noted. Verena Bruno is the GBV subcluster coordinator in Zimbabwe. So thank you. I know we have about 3 minutes left, so let me a couple other questions. 2 questions actually, and then I think we can close, Sharon. So the last question is, or the first question out of the 2, And I think this also speaks to what we talked about in terms of capacity of staff. This is also about confidentiality, referral to other services. And this brings us to the issue of SOPs, or standard operating procedures. Do you have in Zimbabwe specific SOPs for one-stop centers and also for the mobile centers? Because I guess in that document, it would address all of these sort of issues. So Sharon, that's the first question, and then I'll follow with the last.
Oh, yes, Jessica, we do have standard operating procedures for both the static and mobile one-stop centers. And SASA was quite active working with the Ministry of Women Affairs in developing the standard operating procedures.
Wonderful. And where can, we have a lot of organizations on the line who are implementing one-stop centers in their context. Where can they find an example of your one-stop centers? Are those on, can we find them on a website or on the ministry websites? Ah, Verena. I see Sharon. Verena is here supporting you. Verena, as we said, the subcluster coordinator, will share those SOPs. Verena, if you want to put a link in the chat, or if you want to send them, we can upload them as well with this presentation to the gbvaor.net website. So thank you. So yes, to those who asked, yep, Ken, I noted that you would like those. And last question from a preparedness perspective, because we have 2 minutes left to the hour. Our last question, and this is from Christine Appio, who is part of the AOR regional team. Do these one-stop centers during emergencies, do you have set in place a preparedness or an anticipatory action plan in terms of mobile one-stop centers? How easy is it for you to mobilize this resource at the onset of an emergency? And is it part of your preparedness plan? Over to you, Sharon.
Thank you, Jessica. Yes, as an organization, we have an emergency preparedness plan, but additionally, we also sit in the GBV cluster. So it's very easy for us during an emergency to engage the funding partners that we work with closely to also fund the idea. But as a team, we have received intense training in emergency preparedness so that whenever there is a crisis or an emergency situation, GBV services can continue. So during the lockdown, our services remained open to survivors, our call center, our shelters, our one-stop centers, both static and mobile, through the emergency preparedness plan that we have as an institution, and also the support that we get through the GBV cluster.
Great. I like that's a great place to end, because Sharon, you did really reinforce the need for strengthened and strong coordination during emergencies, but also during development times, because as you said, that's the kind of the center of it all. So I appreciate that. And we very much appreciate your presentation, Sharon, and the work that you're doing in Zimbabwe. I think you saw, maybe you weren't able to see, but we had so many questions in the chat, particularly about those mobile services. So you might have people contacting you for additional information or looking online as well. So I want to thank both of our speakers, Joanne and Sharon, for joining us today to speak a little bit more about standards in terms of the delivery of services in one-stop centers. Please also remember that you can go to the GBV AOR, I'm writing it now, or maybe Shiva, if you could put our website in the chat. So the gbvaor.net website, and that is where you can find all of the tools that were mentioned. You'll be able to find the recording of this webinar plus the PowerPoint presentations, and then there are a host of other resources for capacity building and the GBV AOR website. As we said, we are the global coordination mechanism. We represent all of you during this journey. So there's tons of resources for capacity building. You'll find the interagency minimum standards for GBV programming, which incorporates all of these. And then lastly, please do next month. As you know, this is a monthly series for us, the Emerging Practice Series. So next month, we're very excited here at the Regional GBV Working Group for East and Southern Africa. We will be supporting or hosting a one-day symposium on engaging men and boys. And so in place of our hour-long webinar, we will have a day-long symposium that's looking at research and also best practice in how we engage men and boys, both from a prevention perspective and also from a response prevention, so survivors as well. So please do look out for that invitation. My understanding, it will be at the end of, perhaps on the 28th of June. I think we have Christine here, but you'll find more from us at the Regional GBV Working Group for East and Southern Africa. Do look for the invitations to our symposium. We're gathering experts from around the world to talk about engaging men and boys, both from prevention, transformative, preventative approaches, but then also from response perspectives as well. So thank you again. I think we are on the hour. I want to thank everybody for attending on behalf of myself, Jessica Gorham, and our co-chair, CARE International. Thank you for joining us today, and we look forward to seeing you next month at our day-long symposium on engaging men and boys. Thanks, everybody, and have a great afternoon.